right, so did you put it right? Very good. All right, so starting to talk about gastric tumors with gastric polyps. Here you will see actually again that the game is related also to the size of the lesion. The larger the polyp, the more likely that it's going to become malignant or it is malignant to start with. So when it comes to the causes of the gastric polyps, what you're going to find inflammation really to be playing a huge role, and also H. pylori infection to be a cause of many of those entities. So masses or nodules which project above the level of the neighboring mucosa. And the most common type is inflammatory, meaning it is happening actually in a background of inflammation. That's the most common type, inflammatory or hyperplastic types, in about 75% of the cases, and associated with H. pylori, which also mean that it will regress with treatment. And usually they are multiple, less than 1 centimeter in maximum diameter, and the risk of dysplasia is proportionate with size of the polyp. So the larger the polyps, the more likely that they are malignant, and the more likely that they will carry actually a risk of becoming malignant, which means that you need to interfere to, you need to take them out either during colonoscopy or during endoscopy or later on. So this is what you see when it comes to the pathology of the inflammatory hyperplastic polyps. So from the name itself, it is hyperplastic, meaning hyperplasia of the glands, as you can see here, of different size and shapes. Always the variability of the size tells you that most likely this condition is actually benign. You would worry about it when they start to look all the same, because this is also what you call monotonous appearance, which is going to be more with neoplastic processes. This is simply glands that have become irritated from the inflammation, most likely related to H. pylori infection, most commonly present in the antrum. So this is very associated with the H. pylori gastritis that we have talked about 1 centimeter or less in maximum diameter. And you see the enlarged dilated foveolar epithelium, okay? Foveolar epithelium. So that's the inflammatory, the hyperplastic polyp. Then comes the fundic type polyp. If you are using the lecture from last year, please make sure that you read the final sentence here, because this has been updated. So in this case, you find it sporadic or acquired actually. This is following the very wide use of the proton pump inhibitors. So it is very much related to the increased use of the proton pump inhibitors. From the name itself, you find it in the fundus, but there is a subset that you start to find with congenital polyposis syndrome, such as the familial adenomatous polyposis, FAP. So in this case, at one point in time, old Robbins used to say that the fundic type polyps are benign and they never become malignant, and they are never malignant. Now we know that this is not always the case, because there is a chance that they are maybe associated with congenital polyposis syndrome. So in this case, genetic testing is going to be important. And once it actually comes back positive, then they need to be removed and they need to be looked at very carefully, to look for the histology of those fundic type polyps. So remember the association of those polyps with the familial adenomatous polyposis. And when you see actually what they are made up of, they are made up of dilated glands in the fundus, dilated glands, and also it looks like microcysts that are lined by fundic type mucosa, because they are arising in the fundus. And that's where these proton pump inhibitors action is concentrated. So sporadic, but also familial. Very important to keep that in mind. Now, coming to the real deal, which is the gastric adenomas. So gastric adenomas, when you hear the word adenoma, it always carries actually an increased risk of it being malignant or it actually transforming into an adenocarcinoma of the stomach, or really whatever this adenoma is, whether it is in the stomach, whether it is in the colon, in the urinary bladder, wherever it is, adenomas always carry a risk of malignancies. So it is, more common in males than females. And, again, the risk of progression to gastric carcinoma is related to the size, with significant increase when the adenoma is greater than 2 centimeter. So a lot of, in about 30% of the time, you will see that the gastric adenocarcinoma will happen simultaneously with, the gastric adenomas, as we will see in one of the slides here. Most likely to present in the antrum, and all adenomas will carry a degree of dysplasia, and that dysplasia is classified into low and high grade dysplasia. Here's an example of this. So you can see here that there is either, rather than having these dilated glands, you start to see that there is a lot of actually proliferation of these epithelial cells, giving rise to this adenoma right here. And these lesions may be either sessile, meaning without a neck that is connecting them to the gastric wall, or pedunculated with a neck that connects them to the gastric wall, most commonly found in the antrum. Here is a beautiful picture showing you the two processes in one. So you will see in the lower part of the picture the presence of this adenoma right here. It's a gastric adenoma. It does have actually high degree of dysplasia. Here is actually a mitosis that is way up in the tissue. If you recall, mitosis should be limited to the basal cell layer. And also you start to see that the nuclei have started to take, a cigar-shaped appearance. That's very important with adenoma, the cigar-shaped appearance. And that's really hold true for all types of adenoma of the GI. So also when you look at, adenomas of the colon, you will see that those, cells of the adenomas carry of what you call cigar-shaped nuclei. So cigar-shaped nuclei, and then you start to see that there is actually what looks like, piling of these nuclei. So there is stratification telling you that it is a disorderly kind of growth. Now compare this to this one here. So you still, actually, when you look at this cell, you still see a lot of cytoplasm. So the NC ratio is not really that bad, even with this increased, size of the nuclei, this cigar-shaped nuclei. But you look at the upper part of the picture, and you will see that these cells are more, hyperplastic, are more dysplastic than these cells, because the nucleus is large, as much as these nuclei, and even larger. Look at the shape of some of these nuclei, what you call anaplastic nuclei. All of these are actually mitosis, much more than the lower part of the picture. The same, adenoma, a lot more mitosis in this part of this picture. All of these dark dots are actually mitosis, and they are in all different layers of this tissue. So in addition to this, you start to see that there are a lot of cells with less cytoplasm than these cells. So the NC ratio is really very large. Okay, so what you're looking at actually, you're looking at a carcinoma that is arising from an adenoma. Okay, so carcinoma arising from an adenoma, or what is known as intramucosal carcinoma. Now that's actually one way to look at it. If you keep looking at sections from this lesion, if you will, you at one point in time you will see that there will be some kind of invasion. That's going to be the most solid evidence that you need. Either angiovascular invasion, meaning there is a vessel and those cells have found their way into the vessel, or actually invasion of this fibrovascular column right here, that is giving the shape of a villus adenoma. So the fibrovascular core, you will see cells that have invaded these cores, resulting in a full frank diagnosis of intramucosal carcinoma. So that's what you have here, carcinoma arising from an adenoma of the gastric wall. Now the real deal, gastric carcinoma. So gastric carcinoma, it does have high incidence in Japan, where you see that they use a lot, or they eat a lot, consume a lot of actually smoked, salty, food. So smoked food, salty food, preservatives, are all actually, known to have high association with the gastric carcinoma. So it does still have actually this high incidence rate of, of the tumor in those countries, but in the U.S., in the rest of the world, gastric carcinoma's incidence in pretty much all the stomach except the cardia is on the decline. A very important point to be made, and that could be, attributed to probably, change in diet. So you don't eat, and the risk of actually eating, the barbecued food and also the salty food, the preservatives as well. Also less smoking, because smoking is a risk factor of this as well. So all of them play a role in this. However, in the cardia, that's going to not be the case. Why? Because of the increased GERD and the increased incidence of adenocarcinoma of the lower esophagus. Of course, with the increased rates of obesity worldwide, they are all, they come, as one package, and as a result of that, there is increased, cardia, of the stomach, the first part of the stomach, cancer rates. The age of the patient usually is above 50. Most of those tumors come in and as advanced tumors that have been growing on for a while. And the reason for this is that it is an empty organ, it is a hollow organ, and the tumor could actually, reach very large sizes before it becomes, manifesting, most likely metastatic. So as a result of that, the 5-year survival rate is very low at 20%. Now there is, a couple of types of gastric carcinoma, and you can relate that back to the pathogenesis of the disease. You have the diffuse gastric carcinoma, and the culprit here is going to be a mutation in the majority of cases, in about 50% of the cases, of the CDH1 gene, which codes for the E-cadherin. E-cadherin is one of the cadherin genes that keep the cells together. So once those actually, junctions, are weakened, then the cells are free actually to roam around and to become cancerous. And in the other 50%, there is 50% with genetic mutation. The other 50% is really epigenetic mutation related to methylation of this gene. So both of them, could be traced back to the, CDH1. So loss of E-cadherin is a very important step in the development of diffuse gastric adenocarcinoma, as opposed to what you see with intestinal type, gastric carcinoma. In this case, you will see that it is related to the beta-catenin gene, which is a nuclear transcription factor. So in this case, you see that there is hyperproliferation of this tissue. Also to the microsatellite instability. What does microsatellite instability do? You guys recall? When someone having microsatellite instability, which system is going to be affected the most that will result in the development of cancer? The repair, right? The genomic repair enzyme, the DNA repair enzymes are going to be affected. So that's going to result in the introduction of a lot of actually mutation that will not be corrected. Also the hypermethylation of genes, including the BAX. What is BAX involved with or in? Apoptosis, right? So there is lack of apoptosis. And finally, IGFR2. What does the insulin growth factor receptor 2 involved in? Proliferation again. Very good. So proliferation. So they will deactivate, the apoptotic gene, meaning that there will be less apoptosis, and they are going to upregulate, the proliferative gene, resulting in hyperproliferation. P53 mutation is present in both. The H. pylori infection is a risk factor as well, with the intestinal type gastric adenocarcinoma. You have seen that with the kind of changes that happen, right? The intestinal type metaplasia that we talked about, and the goblet cell metaplasia that happens with H. pylori. So those, if they continue unabated and corrected, they will end up creating this subtype of, gastric carcinoma, intestinal type gastric carcinoma. Epstein-Barr virus, they equate Epstein-Barr virus with a lot of diseases. What other diseases do you see Epstein-Barr virus in? Say it again. Speak up, please. Burkitt's. Okay, very good. Wow, very good. What else? Say it again. Post-transplant. Post-transplant what? Lymphoproliferative disorder. Very good. Wow. Okay, what else too? Hodgkin's disease. Does it do with Hodgkin's? Okay. How about actually, let's see. Some types of also lymphomas, are associated with the Epstein-Barr virus as well. So there is a lot actually that has been said about Epstein-Barr. A lot of people, question this association. Now, why is that the case? How could you negate, the association between Epstein-Barr virus and the sequels that they talk about? What is the prevalence of the Epstein-Barr virus in a country like the US, for example? Very high. Like how high? How about 90%? 90%. How does it get transmitted? Kissing, right? They call it the kissing disease. So if 90% of the population are having this actually virus, how come that you don't see that 90%? Obviously, there is more to the story than just simply the presence of it may be and simply a thing that is present there, or if there is an association, you have to prove it in a lab and you have to prove it, also in large studies. So a question mark about the Epstein-Barr virus and its association with a lot of diseases, including gastric adenocarcinoma. Now, there is a lot of risk factors, Of course, lower socioeconomic status is a risk factor for pretty much all diseases, as you know. And the H. pylori is another one. But look at the chronic atrophic gastritis that we have talked about, 5-fold increase. Pernicious anemias, 15-fold increase association with gastric adenocarcinoma. Of course, everything that is good, with diet, all the nice smoked food, the pickled vegetables, salt, right? All my favorite kind of food really, are there when it comes to actually as a risk factor of gastric adenocarcinoma. Of course, there is also family history. Now, how do they present with? Weight loss is going to be there. And weight loss is going to be from cachectin, right? The suppressive effect of the TNF, of the tumor necrosis factor on the appetite center. But there is another reason why there is actually weight loss in those patients. Remember that this is a mass that is growing in the stomach. So there is going to be early satiety as a result of it filling up this, stomach space. Of course, pain and vomiting and nausea. And also occult bleeding. That makes for a very nice question on any exam, right? Because if there is an occult bleeding that you discover in your patient, any patient that comes to your clinic who is above 50 years of age, who's presenting for the first time with iron deficiency anemia, whether a man or a woman, you need to work them up for occult bleeding from the GI, either a gastric carcinoma or colonic adenocarcinoma that may be especially in the right colon, that may be the cause of this bleeding. And half of the patients have palpable tumor because of the fact that it has been growing there for a while before it become manifesting. Now, where does it present? In what part of the stomach do you see it? So you see it in the pylorus and the antrum in about 50 to 60% of the time. You may see it in the cardia, body fundus, lesser curvature, and greater curvature. Now, what are the growth types that are going to be also mirrored in terms of behavior of the tumor? So there is the excavated, the ulcerative that will dig deep, and that's very dangerous because it will reach the vascular network and metastasize. There is the flat or depressed, also another very actually dangerous type that goes into the lamina propria, spreads through the lamina propria, sometimes with no lesions in the mucosa of the stomach. Makes it a very tricky kind of tumor to actually diagnose. And finally, exophytic, even though it looks bulky and large in size, but it is really probably the best type to have, if you will. So it will have protruding cauliflower-like mass. So here is actually a malignant ulcer. It could be a gastric carcinoma that has ulcerated, right? Or actually a malignant ulcer to start with in the stomach. Either way, what are the features of this ulcer that you're looking at? Look at the size. The size looks larger, right, than normal. Okay, it looks almost like probably around 6 centimeter or more. And look at the border. The border looks very much, irregular, if you ask me. The pit does not look as clean as the older one. And there are some areas of hemorrhage, actually, you can see here, and also of necrosis within the tumor wall. So all of this are features telling you that what you're looking, and also the heaped up margin. You know how the volcano looks like? This is what is meant by a heaped up margin. So when you take a look at this, actually, at this section, you take a look at this section, from the side, you will see that it rises above the plane of the gastric mucosa. Now you look, this here, is going to be very hard for you to tell where is the tumor. The tumor really is in the wall. This is what is known as Lionitis plastica, where the tumor spreads through the lamina propria, and in the process of doing so creates a lot of desmoplastic and fibroblastic response in the lamina propria, as you can see here. So if you take a section of this area right here, you're going to be seeing the tumor that results in this Lionitis plastica, and this is actually what is known as the signet ring tumor. Signet ring or wedding ring tumor. I don't know how someone could actually equate or think about wedding and cancer in the same sentence, but I guess the guy who did it is a genius, right? All right, that's a joke too. You can see that these cells are filled with mucin. So in this case, they push the nucleus to the side, resulting in this signet ring appearance, one of the deadliest type of tumors that you will ever find. So, you will see the Lauren classification of this. There is the intestinal variant, the diffuse variant. Of course, the diffuse variant is going to have a much worse prognosis than the intestinal variant because of the fact that the cells are not really cohesive and they can go anywhere. They will go with the flow of the lymph, and also the venous return. And the signet ring tumor, as I mentioned to you, is there as well. So this is the intestinal type. You can see the villi, that should remind you of the small intestine. You can see also, here and there, some of the goblet cells that should also remind you of the goblet cell metaplasia. That was the prelude for that type of tumor. Here you see this signet rings, that are, infiltrating through the lamina propria. And here again, this genius, put this picture with a wedding ring to show the, the relationship between, these cells. So there is so much mucin in these cells. So if you do a mucin stain, it will highlight this cell. It will be highlighted like a Christmas tree, showing that it pushes the nucleus to the side, to the edge of the cell. All right, so in terms of the prognosis, also the depths of invasion, that is going actually to really change the staging of the tumor. The early that you pick it up and the most superficial that it is, the best for the patient, because then you're still probably at 1A or at 1B, where you can still do surgical resection if the lymph nodes are free of the tumor. Once it digs beyond the muscularis mucosa, and into the submucosa, all bets are off, because then the tumor have gone into a much higher stage. It will be much harder to treat. Okay. So penetrate the wall and the serosa and metastasize. Now, when it does that, it is now on the other side of the serosa. It will actually reach the peritoneal fluid. It will swim in the peritoneal fluid, and it will reach organs. In females, it will reach the ovary, usually the left ovary, resulting in a Krukenberg tumor, one of the folkloric appearance of a metastatic gastric adenocarcinoma. May also be happening with metastatic colonic adenocarcinoma, when it goes and penetrates through the full wall and into the serosa, reaching the peritoneal fluid. This is what you call direct seeding, if you still remember it from the POD. Or it may actually go to the supraclavicular node, another actually follicularic part of medicine known as the Virchow node, to the left supraclavicular node. It may metastasize to the skin around the umbilicus, another actually follicularic picture of medicine known as the Sister Mary Joseph nodule. Now, gastric lymphoma is going to be, the about 5% of all gastric malignancies, and is a common location for the extranodal lymphomas. We did talk about, its relationship with the H. pylori. We did talk about its relationship with the H. pylori, which is a very low-grade tumor. We have mentioned it before that it could be treated, if you recall, with antibiotics therapy, right? As crazy as this may sound, you may treat actually this type of tumor with H. pylori, triple therapy and now quadruple therapy that will, treat the tumor and the chronic gastritis that resulted in this tumor in the first place. The second most common is going to be the diffuse large B-cell lymphoma, which is far more aggressive than the very low grade of the marginal B-zone lymphoma, also known as maltoma. All right, so the EBV infection in this case also, they swear by it, that it plays a role in the gastric lymphoproliferative disorder. Now, EBV becomes very important, especially, probably the only time where you can be rest assured that it does have a role in immunosuppressed individuals, especially HIV patients. So with HIV patients, you see that EBV could be a role of brain cancer. It could have a role of gastric lymphoma, and also, in other tumors as well. Okay, yeah, okay. We'll do this. There's about 5 slides to finish. My apologies about the delay, but I think we're done.